Welcome to the Radiology Review podcast, your on-the-go source for radiology education with your host, Dr. Matt Covington, a board-certified radiologist. Please follow the podcast on Twitter at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website theradiologyreview.com.
Welcome back to the Radiology Review podcast, your on-the-go source for radiology board review. On this episode, I will be discussing musculoskeletal tumors. This will be the first episode of at least one other discussing musculoskeletal tumors. I have one quick announcement. If you are somebody who likes to use Instagram, consider following RadRev Podcast for the Radiology Review podcast on Instagram. On this site, I will post updates when I have new episodes and other announcements. I will also post nearly daily tips for the ABR core exam. For those who follow me on Twitter, you know that I have been posting a lot of tips that have lately at least specifically dealt with ABR physics. And on Instagram, these daily tips and pearls for physics for the ABR core exam will be presented in a visual format. So if you prefer looking at things in a more visual way, go ahead and check out RadRev Podcast on Instagram and let me know your thoughts. I hope these are helpful for many of you. Also, at the conclusion of my episodes on musculoskeletal tumors, I will post a free downloadable study guide on my website, theradiologyreview.com. There are other free radiology educational materials available on my website, so go ahead and check that out if you haven't been there yet. Without further ado, let's get into this episode. First question: what are top differential considerations for lytic bone lesions? There are two mnemonics that exist that are really widely known in the radiology community that present top differential considerations for lytic lesions. The first is fog machines, F-O-G, fog machines, and the second is the strange word phegnomashic, not magic, but mashic, M-A-S-H-I-C. Let's go through each of those quickly. Fog machines, and again, these are all lytic bone lesions, or at least in certain cases can be lytic bone lesions. So first, fog machines: F, fibrous dysplasia; O, osteoblastoma; G, giant cell tumor; M, Mets or myeloma; A, aneurysmal bone cyst; C, chondromixoid fibroma or chondroblastoma; H, hyperparathyroidism, which is also sometimes termed a brown tumor, or also for H, hemangioma; I, infection; N, non-ossifying fibroma; E, enchondroma or eosinophilic granuloma; and S, a solitary bone cyst, which is sometimes called a unicameral bone cyst. The alternative mnemonic is phegnomashic, F-E-G-N-O-M-A-S-H-I-C, and this stands for F, fibrous dysplasia or fibrous cortical defect; E, enchondroma or eosinophilic granuloma; G, giant cell tumor or geode; N, non-ossifying fibroma; O, osteoblastoma; M, metastasis or myeloma; A, aneurysmal bone cyst; S, solitary unicameral bone cyst; H, hyperparathyroidism or brown tumor; I, infection or infarction of bone; C, chondromixoid fibroma or chondroblastoma. I would remember one of these. You don't necessarily have to do both, but one of them should help you with many questions you can encounter on the ABR core exam. There are some differences between these. Go ahead and check out the study guide on my website as soon as that is posted to see which one of these you prefer if you don't already have your favorite. And I will not cover all of these entities on this episode. I will cover several of them, but make sure that you know all of these entities. So you should focus on key features and ways to differentiate one entity from the other. Next question: what location is most common for enchondromas? The answer I am looking for here is the hands and feet. The most common location for enchondromas are the hands and feet. Those sites account for approximately 50% of all enchondromas. Note that malignancy of the fingers or toes is rare, so if you see a lucent lesion in the bones of the fingers or toes, an enchondroma should be high on your differential diagnosis. Enchondromas are typically intramedullary lesions, and if you encounter a question that asks you about an enchondroma that is painful, you should consider the possibility that the enchondroma has led to a pathologic fracture. Next question. What are differential considerations for an enchondroma of the hands or feet? I'll throw out a few top differential considerations here. First, brown tumor, which, reminder, that is related to hyperparathyroidism, or sarcoid, or an intraosseous ganglion, or metastatic disease. From my own personal experience reading PET scans, one cancer that I have seen on multiple occasions end up in the bones of the hands is lung cancer, so tuck that away. Perhaps that could be helpful. But other cancers could also, in theory, metastasize to the hands and feet, although that is a rare occurrence. Next. What is bizarre parosteal osteochondromatous proliferation, otherwise shortened to BPOP, or also sometimes called a Nora's lesion? What is BPOP? Bizarre parosteal osteochondromatous proliferation, or BPOP, or a Nora's lesion, results from heterotopic ossification that can form mass-like lesions that arise from the periosteum, commonly of the phalanges. This is an acquired exostosis, meaning it is reactive, and it is often post-traumatic in etiology. So I would look for some history of prior trauma. That is the nidus, you could say, for the subsequent heterotopic ossification that can form these mass-like lesions in BPOP. Other features of this include lack of cortical disruption. A common location is the proximal phalanges of the hand, and a differential consideration is a juxtacortical chondroma. It is important not to confuse BPOP with a chondrosarcoma or osteosarcoma. BPOP is benign, and it is most common in patients under 30 years old. Again, BPOP will show cortical continuity with the lesion and lack of medullary involvement. BPOP is a benign lesion that may be locally aggressive and recurrent following excision, but it is thought to have no or very little risk of distant metastatic disease. There is a lot to unpack there. If you are unfamiliar with this entity, please look up BPOP and tuck that away for the ABR core exam. Next question. Chondrosarcomas may be secondary to what lesions? In other words, what lesions can degenerate into a chondrosarcoma? I am really looking for two primary entities here. The first is an enchondroma and the second is an osteochondroma. Both of these may degenerate into a chondrosarcoma. Note that a primary chondrosarcoma is also possible, so they do not have to be secondary. You can have a primary chondrosarcoma. For review, chondrosarcomas commonly involve the pelvis, femur, and humerus. Characteristic features of a chondrosarcoma include a lobular growth pattern with high T2 signal that can result from high water content and cartilaginous nodules within the chondrosarcoma masses. A buzzword for chondrosarcoma that you need to know is the rings and arcs pattern of chondroid mineralization that is best depicted by CT imaging. Also, endosteal scalloping and soft tissue extension are ways that you can identify correctly a chondrosarcoma. And remember that if you start to see these features in what was an enchondroma or an osteochondroma, you now need to be concerned that a chondrosarcoma may be present. Next question. What may be the best feature to distinguish between an enchondroma and a chondrosarcoma? The answer I am looking for is endosteal scalloping. That at least can be something that can help you lean towards chondrosarcoma rather than an enchondroma. If you have increased length and depth of scalloping, which often is considered scalloping that extends greater than 2/3 of the normal cortical thickness of the bone, this is suggestive for a chondrosarcoma. Next, what are the 3 most common malignant bone tumors? The answers I am looking for here are myeloma, osteosarcoma, then chondrosarcoma. I believe in that order. So the 3 most common malignant bone tumors, first myeloma, then osteosarcoma, then chondrosarcoma. Next, most chondrosarcomas are well-differentiated low-grade tumors. What are imaging findings that suggest a dedifferentiated high-grade chondrosarcoma? If you see a chondrosarcoma with a soft tissue mass, and that soft tissue mass does not demonstrate bone mineralization or a mineralized matrix, this is suggestive of a high-grade malignancy, a high-grade chondrosarcoma. Some have termed this a bimorphic appearance. So when chondrosarcomas become high-grade tumors, they start to have a bimorphic appearance where part of the tumor may be mineralized with that typical arcs and whorls pattern and the other features we have discussed, and part of the tumor may now contain a soft tissue component that is not mineralized. That can be a sign of a high-grade chondrosarcoma. Next question. What are key features of a telangiectatic osteosarcoma? I have to tell you, at least from what I remember about studying for the ABR core exam, the topic of telangiectatic osteosarcoma seemed to come up over and over again in my board study, so I do believe this is important. What are key features of a telangiectatic osteosarcoma? In terms of location, telangiectatic osteosarcomas would be most typical for the distal femur location. Also, the tumor has necrotic and hemorrhagic portions with multiple fluid levels, and that is absolutely key. If they show you a bone lesion, especially in a distal femur location, you have to consider the possibility of a telangiectatic osteosarcoma with those fluid levels that look so nice on images and therefore end up being tested and discussed with some frequency. Next, what is the top differential consideration for a telangiectatic osteosarcoma? The answer I am looking for here is an aneurysmal bone cyst. In terms of aneurysmal bone cysts, approximately 2/3 of these are primary tumors. You can have a secondary aneurysmal bone cyst that may arise from a giant cell tumor or a chondroblastoma, among other entities. Note that of the lytic lesions, an aneurysmal bone cyst tends to be the most expansile lesion. So if you are shown an image of an highly expansile lytic lesion, an aneurysmal bone cyst should be a top differential consideration. Next, what are key features of a chondromixoid fibroma? A chondromixoid fibroma is a rare, eccentric lytic lesion that is most common in people under 30 years of age. A chondromixoid fibroma is typically in a metaphyseal location and would classically be seen around the knee. Chondromixoid fibromas can show cortical thinning, and they have been described to contain pseudotrabeculation, which means that the lesion is septated and can look like trabeculations, although what you are really seeing are septations. Chondromixoid fibromas typically do not have periosteal reaction associated with them, and a chondromixoid fibroma would be expected to have a sclerotic, well-defined margin. Got it? If not, go ahead and read more about this entity as well. Chondromixoid fibroma is one that I always have a hard time keeping in memory and need to keep reviewing, so go ahead and look up some images and read about chondromixoid fibromas. Next question. What is the classic location on board exams for an adamantinoma? The tibial diaphysis is the classic location on board exams for an adamantinoma. Adamantinomas are very rare lesions that may be multicentric. These appear as eccentric lesions that classically involve the anterior tibial cortex and much less commonly can involve the fibula. Adamantinomas are often indolent lesions with risk of late metastases to the lungs. A classic question on a board exam could include a primary lesion of the anterior tibial cortex that is treated and then recurs and then shows late metastatic disease to the lungs. I believe that despite being rare, adamantinomas are high-yield lesions on the ABR core exam, and you absolutely need to be aware of this entity. Next, true or false? Synovial sarcomas arise from joints. The answer is false. Despite the name, synovial sarcomas arise not from the joint itself, but in close proximity to the joint. Synovial sarcomas are most common in the extremities and present as juxta-articular lesions. A classic history on a board exam for a synovial sarcoma could be a pediatric patient with a multicystic appearing mass with well-defined margins that is located around the knee joint. Note that synovial sarcomas can also be seen in close proximity to other joints, to include the ankle. Next, what is the triple sign of a synovial sarcoma? The triple sign of a synovial sarcoma refers to the heterogeneous signal that you can get on MRI imaging due to the synovial sarcoma having three parts. First, a solid mass. Second, hemorrhagic components. And third, calcification. So that can lead you to the triple sign appearance of a synovial sarcoma. Next, what is the bowl of grapes sign of a synovial sarcoma? I think this is somewhat intuitive because we all know what a bowl of grapes looks like. The key is to associate this bowl of grapes appearance with a synovial sarcoma, and this looks like a mass that contains multilobular components, which are the multiple cyst-like areas that can demonstrate diffuse blood fluid levels. So remember, synovial sarcoma can show the triple sign appearance and or the bowl of grapes appearance. Time has flown, at least for me, and we are now at the last question for this episode. What are imaging features suggestive of a well-differentiated, dedifferentiated, pleomorphic, and myxoid liposarcoma? Let's talk about some imaging features that suggest the following subtypes of liposarcoma: well-differentiated, dedifferentiated, pleomorphic, and myxoid. First, a well-differentiated liposarcoma often will show a large majority of fat within the lesion. Something like greater than 75% of the liposarcoma will be fat-containing. You also can see slightly thickened septae, which I have seen defined as greater than 2 millimeters in size. And you can see some soft tissue nodularity, but still the major component of a well-differentiated liposarcoma would be that fat content that also contains some thickened septae and some soft tissue nodularity, which lets you know that this is not a simple lipoma. Next, a dedifferentiated liposarcoma will often have larger nodular components, and specifically, you are looking for a nodular dominant focus that is greater than 1 centimeter in size. If you start to see those nodular areas that are getting larger than 1 centimeter in size, this may now meet criteria for a dedifferentiated liposarcoma. Next, a pleomorphic liposarcoma would typically look much more heterogeneous and now has dominant soft tissue components and only small fat-containing foci. So if you now see much more soft tissue and much less fat, you need to consider the possibility of a pleomorphic liposarcoma. Finally, a myxoid liposarcoma. And when I say those words myxoid, you should automatically think in your brain T2 bright. That holds true for many myxoid lesions, including the myxoid liposarcoma. And this entity often shows a classic myxoid background with the T2 bright appearance and would contain some nodular soft tissue and some adipose tissue components. That's enough for now. I hope this review of musculoskeletal tumors has been helpful for you. There's definitely an opportunity to do some additional self-study on your own, I imagine, and these musculoskeletal tumors can really be tricky, so it is worth investing some time to learn these. I will continue our discussion of musculoskeletal tumors on the next episode. Remember to follow RadRev Podcast on Instagram to get some near-daily tips on ABR core exam study. That will be presented in a more visual format than what I have done on Twitter so far. I want to address one question I have received based on my previous episode of quality control in mammography on whether you really need to study quality control for film screen mammography. The most honest answer I can give you is I truly do not know. I think it is outdated information that you are unlikely to encounter in real-life clinical practice. However, if you look at the ABR core exam study guide on the ABR website, they have listed screen film mammography, including acquisition of screen film mammography images in the study guide. And until that is removed, I think you are better safe than sorry to go ahead and study some of the quality control parameters that have in years past been classic questions for ABR core exam study. And understanding components of screen film mammography quality control is one way to maximize your preparation for the examination. But perhaps you should prioritize other areas in terms of how you allocate your time for board exam study. Thank you for listening to this episode. Keep up the good work, study hard. Remember, you have to study really hard to succeed on radiology board exams, so prepare to succeed. I will catch you on the next episode. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.